just like look at something and follow the number or follow the dot or something like that, so that it helps speed up that information processing. Restorative training is usually computerized. Brain HQ, Lumosity doesn't have as much evidence base to it, particularly in psychosis disorders, but Brain HQ does. CET, cognitive enhancement training, which was developed by Eat et al., also has a great deal of evidence to it. Compensatory programs are usually delivered either individually in therapy or in a group setting. It's usually better in a group setting, but can be done individually. It's manualized, and again, it focuses on skill development. There's lots of treatment efficacy. So restorative programs show improved cognition up to 36 months from the end of treatment. So it really does show that improvement in cognition and an improvement in treatment adherence. However, it's a compensatory training program that show that improvement in functioning. There's also changes in neurological brain structure and function. So as Dr. Shapiro was saying earlier, that improvement in that prefrontal cortex, which is about right here, you see that with the restorative programs and a bit with the compensatory programs. Vocational training is something that has been shown in the past decade and a half or so to be particularly helpful. When someone has been derailed in their course of life because of this illness, getting back on track means, okay, I have this like 2-3 year gap in my resume. How am I just going to go out and talk about that on interviews? Well, let's practice. Having to re-up their social skills and their interviewing skills, how you talk about certain things at work. How do I disclose this illness to HR so that I make sure I get the appropriate accommodations that I need? Things like that. So really making sure that we're working towards helping them get back into the workforce. So the interventions can be a supported education and employment specialist who works directly with them and does some individual placement and support. There's lots of, so in California we have a Department of Rehabilitation that works with individuals who have identified disabilities, either physical or mental, and helps get them back into work. Their employers are ones that work with the DOR who are able to accommodate these different issues. And it does a lot of skill development. There's a lot of efficacy shown with skill development through vocational skills training. There's an improved rate of interviews, improved job procurement, and improved cognition as well. But it works best when it's coupled with IDS, which is being able to show that you can get someone into a job. Coupling both of these is helpful because IDS gets you that first job, but vocational skills training helps that continued upward trajectory for a lot of individuals. So physical activity tracking and weight management is something that's gained more interest in the past 5 to 10 years. And it's particularly helpful because of some of those side effects we talked about in medication. The weight gain, the metabolic factors, the cardiovascular risk factors. So there's been some interventions, and they range in how structured they are. So sometimes it's just like providing psychoeducation. You should do strenuous exercise for 30 minutes 3 times a week. You should restrict your caloric intake to 1,500 calories per day. So having them go to classes that inform them of what they should be doing versus all the way up to fully structured is, okay, we offer a class here with a physical trainer 3 to 5 days per week. It's 30 minutes. You get paired with someone, you have an accountability partner, you have a fitness tracker, here's your calorie counter. And so the more structured it is, the more evidence it has to actually work and have continued impact following that. So you'll see increased activity and weight loss. There's improved functional outcomes as well, improved cognition. And that's a big one that I think a lot of the researchers hadn't expected, to see that kind of improvement in cognition. That increase in speed of information processing, increase in memory, was particularly important in these studies. And there was a lot of also improved socialization, because now you're like, hey, let's be gym buddies, let's go to the gym together. And so since you have a directed activity where you don't feel like you have to talk a lot, but you're still socializing, got a lot more people to engage socially. Treatment outcomes, as I said, are linked to how much structure is provided. Okay, so we've talked about a ton of different treatments, And really what we want to focus on is how we're able to integrate this to help our clients. So we are going to do a small group activity. You're welcome. I'm sure you're very excited to do this. But if you could all smush together here in the center so that you can break up into, or you don't have to, but break up into small groups of about 3 to 5 individuals. And I'm going to present a case to you. What we'd like for you to do is spend the first 10 minutes just kind of discussing the case, really outline the case conceptualization based on the CBT framework. And then spend about 5 to 7 or so minutes coming up with a treatment plan. How would you target the symptoms that I'm going to present that this client has? And then we'll leave about 5 minutes or so for a group discussion on what sorts of things you came up with, how you really conceptualize this client. So this is a client I previously had, Kay. She is a 25-year-old cisgender heterosexual female. She lives at home with her parents. Her brother lives nearby with his wife and family. And her parents work and are pretty socially active. She's really close with her family. And she was really socially active as a child. She was about an average student and had a goal of being an engineer. She was diagnosed with schizophrenia at 21, so she started having symptoms about junior year in college, had to drop out, and then she got diagnosed. She now needs criteria for severe affective disorder depressive type after she's had multiple major depressive episodes. Early years of the illness, she had a lot of paranoia, thoughts of being monitored, pretty severe depression, and some alcohol dependence and social isolation. She stopped talking to friends, she stopped talking to her family even, really didn't engage. She has a significant history of treatment adherence, but she has resistant auditory hallucinations. So this is through multiple rounds of different antipsychotics, ultimately getting on clozapine and having ECT treatments. So a lot of different things, it's still, she was having daily auditory hallucinations that told her that they were going to sexually assault her family. The voices that tell her to hurt, that they will hurt her or her family. She doesn't comply with their plans, and sometimes they're pretty serious in nature, hurt yourself, and sometimes they're innocuous, don't eat chocolate, and for anyone who loves chocolate as much as I do, that's actually a pretty serious one for me. That would be very destructive. And so she has a lot of trouble not complying with the commandments. And her goals are to improve her social network, get rid of her symptoms, and get a job. So with all this said, and bear in mind that there are some barriers here, I'm sorry, there probably walked a little bicycle, but there's low to mid SES. She doesn't have a great deal of financial resources. Symptoms interfere with transportation, makes it hard for her to drive. Sometimes the voices will tell her to swerve her car into oncoming traffic. And then some kind of anxiety. So I see a few people have left. They're not real excited to talk about these things.
People who use avoidance.
What'd you say?
Question. So this was an actual patient you had, correct?
This was a patient I had.
So do you, with the clozapine, is the plasma level something that you're now looking more closely at?
We monitored her
to determine
level, and she was at the max.
You're monitoring the norclozapine level, correct?
Yeah.
Okay. And so as it escalates or de-escalates, is there things that are driving plasma with the clozapine group above or beyond the indicated therapeutic level?
So
No.
we don't have a ton of time left.
Gotcha. All right, I'm just
We're
curious.
trying to make the point that interventions that follow a conceptualization are more effective. This is true. This is an empirical finding. We were hoping that you could put some of the pieces together here to create a conceptualization for this person. What may be driving their difficulties, and what treatments you might suggest as a result. So clozapine could be one of them, right? But there may be some other psychological treatments that you might use, some of the ones that we showed you. It should follow from your conceptualization. So for those of you that are left,
not a ton.
we are hoping that you will take a few minutes. We don't have a ton of time. But talk with some of your neighbors for about 20 minutes. See if you can make some sense. Come up with a conceptualization. If you like CBT, use CBT. If you like something else, use that other thing. And what treatments would you identify and might you start with as a result of your conceptualization? So, sorry to cut the question off, but we can talk about that afterwards. I want to make sure we have some time for questions.
Yeah.
Does that make sense, people? Questions? People interested in doing this? Some were not. Sure.
It's okay if you're not. But it could be fun.
I think this is important. We so often, when we see psychosis, we are attracted by the fires, right? We want to jump in and help with something, but we need this theoretically driven conceptualization to have our most effective results.
All right.
Yeah.
Go for it and chat. We'll check back in with you guys in about 10 minutes. Have fun. So you guys can make a group. There's a couple of people back there. Yeah. You can do 2 big groups.